Hello and welcome to another bite-sized episode of Home of Medicine podcast with me, Dr. Ben Lovell, and my very good friend,
Dr. Amy Burbridge. Hello.
So on this bite-sized episode, I thought it'd be nice to do clinical pearls, just little pearls of wisdom. And I'm going to ask you, what is your favorite? I know you like these. What is your favorite medical mnemonic to remember something in clinical medicine?
Okay, you're right. I do love a clinical pearl. I think I must say in every episode, every woman is pregnant until proven otherwise. And I think I also must say, listen to your patient. They are telling you the diagnosis in every episode as well. So I'm not going to talk about those. However, I'm going to tell you my favorite, one of my favorite mnemonics. I have a few. So explain. Explain is a mnemonic for causes of hypoglycemia. And often when I've got a patient who's hyperglycemic, I do run through this mnemonic, even though I've been using it as a medical student, as a trainee, as a consultant. I still use it now because I find it really helps me focus on the cause of hyperglycemia. So
I guess so.
Go on then. Go on. Yes.
I know this mnemonic and I'm very intrigued to know what X stands for.
Okay.
So E, I'm going to guess, must be exogenous drugs or insulin or something.
Yes.
Yeah. So basically, are they taking insulin or sulfonylureas, which have lowered their blood glucose? X, I have no idea. What does X stand for?
Well, I've cheated, and the X is for the exogenous insulin.
I thought that was E.
Yeah, I know, but I've added the X to the E.
Oh, okay, so E and X goes together. Gotcha. Okay, that makes sense. So going on to P. Pancreas diseases of some description. Go on.
Okay, yeah, I'll let you have pancreas diseases. Okay, pituitary as well. So if you've got pituitary abnormality and pancreatic abnormalities.
Pituitary/pancreas disease. Gotcha. L. It's got to be liver failure.
Yes, absolutely. So it's liver disease. So obviously the liver plays a very important role in glucose production, in glucose storage as glycogen. So if you've got an abnormality within your liver and you aren't able to store your glucose or you release your glucose for whatever reason, then that can cause hyperglycemia. So absolutely, liver disease is L. Well done.
I'm stuck on A.
Addison's disease.
Oh, Addison. Oh, that's rare. Okay, but fair enough.
Yeah, I know. I didn't say these are common causes of hyperglycemia. But Addison's disease, we think it's rare, but actually we see quite a bit of Addison's disease.
Really?
Probably more steroid-associated Addison's disease, where people have come off their steroids and they have that Addisonian type picture actually, rather than primary autoimmune Addison's disease or Addison's associated with TB of the adrenal glands, for example. So you're right. It's uncommon, but we do see it.
Okay. Can't be insulin. We've done that under the EX at the beginning. Oh, insulinoma. Or is that?
Yes, you're right. So if you've got an insulinoma, you obviously are going to be producing excess amounts of insulin. So if you're producing excess amounts of insulin, what's going to happen to your glucose is obviously it's going to drop. Yeah.
And the N, I'm wondering if you're going to say nutrition, and if so, if that was a bit controversial, because I don't think you can get hungry enough to be hypoglycemic unless you actually have a dysfunction of that particular hormonal axis. Were you going to say?
I've actually got, I'm not going to say nutrition, I'm going to say neoplasm.
You were going to say what?
Neoplasm.
Okay, which neoplasm do you mean?
Well, if you've got a malignancy in the pancreas, potentially. So again, I'm linking this with the pancreatic pituitary abnormalities, but that could lead to hyperglycemia. And any sort of malignancy that has got metastatic spread, that has a very high metabolic turnover, can also cause a hyperglycemia. So these are more patients who are very, very sick with their malignancy and have multiple metastases. Yeah.
And people who've got, as you say, disseminated malignancy and they're a bit underweight, a bit cachectic, and they have poor insulin glucose stores anyway, and they can get recurrent hypos. And I've seen that being treated in palliative care with prednisolone, just 5 or 10 milligrams a day, just to maintain euglycemia in these patients.
Yeah, and it can also, when you have a steroid, it can also help increase your appetite as well. So you might feel like you want to eat a little bit more as well. Yeah, absolutely. You did it. Well done. So that's my favourite one for hyperglycemia. There are probably other causes, more rare causes, but that helps me sort of set my mind. And I'm interested to hear what you were saying about the hyperglycemia caused by not eating enough.
Yeah, but you know when people say, "Oh my gosh, I'm so hungry, I'm starving, I'm hypoglycemic,"
Yeah.
you can't be. Your body still
I
maintains.
don't know.
Well, let's get our what are those little things our sensors, and we'll check. We'll do it over a couple of weeks to see how hungry you can get.
You
But
just think I need one of those monitors. I it'd be really interesting actually to monitor blood sugar levels, I think, throughout the day to see what happens when you're on call and whether, you're not really eating very well and whether when you're stressed, what happens to your glucose. Be really interesting. I know there's obviously work being done on this elsewhere. But I do think my sugar levels do drop sometimes when I become neuroglycopenic,
I
when
knew
I
you were going
can't,
to say that. Yeah, I say hangry. You say neuroglycopenic.
I can't function because my brain's got no sugar. But anyway, so that's the causes of hyperglycemia for me. So Ben, have
Yeah,
you got a mnemonic that you would like to share with us?
pinch me, pinch me, and then I'll tell you my mnemonic.
Okay.
Pinch me. This is my mnemonic for delirium.
Yeah.
Okay, because people come in with delirium a lot in acute medicine, older adults, and I think we're brilliant at looking at, let's rule out infection, or let's scan their heads, or let's check a few metabolic parameters, and then sometimes we stop. So pinch me is sort of a more holistic way of looking at the different triggers that a vulnerable older adult can develop delirium. Do you want to guess them like I did, or shall I tell you?
Well, I know them, so I'm not going to be guessing them. I'll be cheating.
You could have not told me that and got a 100% score and sounded really intelligent. I'll do it then.
Okay, go
So
on then.
P is for pain, uncontrolled pain. Uncontrolled pain for me and you is extremely distressing and unpleasant. Uncontrolled pain, if you are vulnerable, can cause delirium. And not everyone in delirium can actually signal that they're in pain, or communicate the fact they're in pain. So we have to be quite adept at looking for clues for pain. With our examination, a careful examination, placing a hand on the patient and examining their reaction in their face, and also asking people who know and who love them, has this happened before? Were they in pain before this happened? And do you think they're in pain? Which I find is actually a really useful way of finding out. And sometimes one of the pains is urinary retention. So I always feel to see if they've got a big palpable bladder, I can tap out palpable bladder, because that's quite difficult sometimes for delirious patients to convey. That's me P. I is infection. And I think everyone sort of knows this one. Oh, there must be a UTI. Why else would you get delirious? It must be a UTI. We love diagnosing UTIs in older, especially older women who are a bit delirious. And fair play, sometimes that is the cause, but not always. But this is just prompts us to do our infection screen. N can stand for a couple of things. It can stand for nutrition, i.e., the patient is just really, really hungry, or is underfed, or is malnourished. But also N can stand for noise. And I think that is really prevalent on AMUs. I don't know about your AMU, but mine seems to be designed to be the most noisy place within the hospital, with doors, bins slamming, alarms going off, multiple parallel consecutive ward rounds going on, discussions about who's got the keys, the tea trolley coming around.
The Hoover.
The Hoover, yeah. The guy doing the floor when you're trying to break bad news behind the
Every
curtain.
time the Hoover comes out. Oh, it's like the one with the big brushes on the bottom. Yeah.
But someone in a very noisy environment, which is very overstimulating, can actually precipitate a delirium in people who are on the so. So that's my N. The C is constipation. I think we're pretty good at remembering this one. If sometimes when older people get constipated, it can lead to delirium. And also under C, you can think about continence as well. It's a nice place for remembering that urine retention if you don't remember it under pain. H is hydration status. So are they dry? Have they not been drinking enough fluids recently? They've become dehydrated. That's a really common one, I think, as well. And also H can stand for your hypo and hyper. So when you get your hyponatremias or your hypercalcemias or any other electrolyte derangement, I file away under H as well when I'm looking for the causes. And then M, we get to medication. So this is an iatrogenic cause of delirium. What do you think are the big ones, the heavy hitters for causing a delirium in older adults, meds-wise?
So medications wise, I'm going to go for pain relief. So codeine, the morphine based products.
Yep.
Number 2 is our anxiolytics. so benzodiazepines, zopiclone that's given at night.
Yeah.
They can be a problem. Other medications that can sometimes contribute are diuretics. They're going to be causing hyponatremia, dehydration. So indirectly, they can also cause delirium. Some of our anticholinergic medications as well can contribute to it. And sometimes it's just the combination of the drugs themselves working synergistically together that can also be problematic.
So definitely looking at the cholinergic burden of the medications they're taking. There's actually a cholinergic burden score you can do on MedCalc to see what the likelihood of that is in affecting their cognitive function. But the big ones, as you say, are narcotics, so the opiates and the sleeping tablets and the benzos. And I remember the geriatrician telling me very clearly that every time you give one older inpatient one dose of benzodiazepine, you're adding 2 days onto their inpatient stay. So think very carefully before you ever reach for a Loraz or a diazepam or anything like that. And that's the M. And the last one is E. And we kind of covered it with N for noise, but it's environment. It's being in an environment outside of your routine and outside of what's familiar to you can cause a really, really profound delirium. There was a vogue many years ago for trying to get delirium orientation clocked on every ward. Great clock that are visible from the bed space that says this is the date and this is the time. The idea being it helps us orientate them. So when we come around and do our mini mental examination saying what day it is, they're not completely flummoxed. I'll tell you something, we have those clocks on our wall and the batteries have gone in a lot and the time is always wrong and the date's wrong. And that is iatrogenic disorientation. But trying to make sure that they're in a place where they recognize the environment, moving someone who normally lives bed, chair, TV, lunch, carer that they know, day center, TV, bed, and moving them from that to a place where there is no night and day routine. Everything's noisy, unfamiliar faces coming around, prodding and poking them, doing blood tests, doing blood pressures. Someone can come in not delirious and then become delirious as an inpatient. We've all seen that. And that's because of that environment issue. And I think that's a pretty good mnemonic and it covers quite a lot of stuff. I can't think of anything that it might have missed out.
Yeah, I love that one. And I think with most mnemonics as well, each letter can have different meanings. So like N for nutrition and noise, I love it. And it's one that I do use at work as well. Thank you very much.
Brilliant. Well, I'm glad you found it useful. I'm glad I got a pretty good score on your explain mnemonic hypoglycemia. I shall take that forward. And thank you for joining me for this bite-sized Clinical Pearl episode, Amy. Great to see you again.
Thanks for listening. Goodbye.
You've been listening to the Home of Medicine podcast, a podcast brought to you by the EFIM Academy in association with the European Federation of Internal Medicine, a leading organisation in internal medicine. Thanks for listening.